So Dave, of course, had to start with a joke, which then made me need to start with a joke because, you know, us evaluators are competitive about such things. And so I'll go ahead and do that. What the heck? We'll go over, Sandra will throw things at me, I'm used to it. So there's a man in a balloon, and he decides he wants to go from Los Angeles to New York, and he's floating across the country, and it gets all cloudy around him, and he realizes he's lost. So he brings the balloon down into a farm, and he sees a farmer down there. And he looks down at the farmer, and he goes, "Excuse me, sir, can you tell me where I am?" And the farmer looks up at him, and he goes, "Well, you're in a balloon, and you're 20 feet in the air." And the guy in the balloon looks down at him, and he says, "Well, you know, you must be an evaluator, because the information you gave me is exactly correct, but it's of no use to me whatsoever." And the guy in the balloon looks down and says, "Well, you know, you must be a policymaker, because you don't know where you are, you don't know where you're going, and now you're trying to blame me." So, one of the things I was asked to do was sort of summarize my experience over 20 years in doing it, and that probably summarizes it right there. I've been the guy on the ground. So a little trip down memory lane. For those of you, and there are many faces I see in the room who have been a part of this, and all of you are entirely innocent of this process, and anything that went wrong was definitely my fault. We've been here before, and California's been here before with child adolescent mental health in terms of measuring outcomes. And actually, not only are we not, have we been here before, but we're not alone. This is going on nationally. I'm sure you've all heard different things about that. This began with the Children's System of Care movement in California. A little trip down memory lane for you, all of you. Began in Ventura County, California. Woohoo! Yeah, I was just down there surfing. Yeah. I love that place. And it began really with the idea of assessing whether young people were in home and school out of trouble. And one of the interesting things about that was that the goal here was to demonstrate the value of mental health services to other agencies, because mental health services for children and adolescents was a very small thing in those days. And the other agencies, probation, juvenile probation, education, and social welfare, really had most of the resources and the strongest mandate. And so the initial indicators really looked at indicators of use to those agencies in part. And the argument was made for system of care based in part on those outcomes, and of course the monetary and efficiency argument, the reduction of costly out-of-home placements. This is not news to some of you and news to others of you, so I'm going to go ahead and just fill this in. At some point, folks thought we needed some functional measures and more mental health type measures, and the legislation changed and included a requirement for measures of functional and clinical status. And in those counties, initially in the system of care counties, we put in place the child behavior checklist, the youth self-report, and the child and adolescent functional assessment scale. So for those of you who are using those in your agency, or those counties that still have some of those measures, I know when I arrived at AMQ Families First, they had those measures in place. It's in part because there was actually a system of care, and then later statewide, a system based around those measures. And they lingered or did not in certain places. There's also satisfaction. So we did have a statewide system with fairly extensive, some would say too extensive, including me, measures that was in place across the state, and that data was collected. There was also a satisfaction measure. Then that became the original statewide performance outcome system, and then that evolved to what most of us know now as the performance outcome system for children using the youth satisfaction survey, the YSS, and that is still underway, sort of on again, off again, and being collected. And that's a very different kind of approach. So the children's system has been here before, and the children's system in California actually mirrored and mimicked for no particular reason other than actually all of us were involved in doing the same thing. Many of the counties in California that were measuring outcomes were involved nationally. Many of us in California were involved nationally, and there was a lot of interaction going on in those days. And there was a large initiative, the Children's Mental Health Initiative, that's the largest funded initiative from the federal government, that used some of these similar measures, and that initiative is still underway, and there are counties in California who have that funding, and they collect outcomes according to that. Measurement strategies did evolve over time, as they would, from the CBCL and the YSR and these very good but traditional measures, and so there are a lot of other measures, including a lot more measures that emphasize strengths more than those original measures did. And so when you get to where we are now, there are some choices. I think for many years, sort of my definition of success was moving from one failure to the next with undiminished enthusiasm. And at some point, one's enthusiasm starts to diminish. And so there are some choice points, I think, generally now when folks go to measure outcomes for children and adolescents that weren't around even 10 years ago. And you have some choices. You can choose from some of the newer, traditionally developed measures, meaning psychometrically based, traditional kind of measures. There are very good ones out there. You've heard some of them today. You could decide that you don't want to even go there and ignore clinical and functional status and say with these in-home, in-school, out of trouble indicators. That's always an option. Or one can go in a new direction. And by a new direction, we'll talk about that in a second, what that could mean. There are challenges to measuring outcomes for children and adolescents. Most all of you know this, but it's worth repeating just because it's a repetition compulsion. One, of course, is the problem of development in children. I have a 16-year-old. He's nothing this week like he was last. But he's especially nothing like he was when he was 12 or even 14. Many of us don't change much. People haven't seen for many years came up to me and said, "You're exactly the same." I'm like, thanks. You know, so we don't change that fast as we get older, but children, of course, really do. There's also the problem of multiple perspectives. Children are certain kinds of informants, and their capacity to be informants changes as they develop as well. And so you have adults who are informing, you have caregivers, you have teachers, and children's behavior changes across these contexts. And so one of the problems with the informant problem is that you get different perspectives, and it can get really hard to reconcile it. So actually, at one point, we looked at the children's mental health outcome system in California, and we took a look at the measures. And what we found was, depending on how you analyze the measure, you could say children's mental health services in California were either 20% successful or 80% successful, depending on which perspective you took or how you combine perspectives. That's not exactly going to give you a lot of confidence about what that means. It makes it very hard to do that. And then there are also these kind of objective indicators I mentioned, which are very important, but they're really not sufficient, and they're especially not sufficient in the area of healthcare because they don't give you enough level of detail about what's happening in outcome. So for example, a young person could be living out of home, but yet doing fairly well in that out-of-home setting, so maybe that is actually where they should be. So that, even though the general goal, of course, is for young people to be living in their family environments. So you have to sort of think more about some of these subjective things. The other thing that I think is important to remember, of course, of California, which you all know, and nationally, is the influence of the system of care philosophy and wraparound, and the need to be attentive to those values and principles as you go along. And there's finally the communication challenge of traditionally developed measures, much of which are based on sort of scales, and it's very hard to talk about what these mean. I have been in many presentations where I have utterly failed at doing this. And so you get up and you talk to a group and you say the T-scores went from 20 to 40 on the CBCL. And someone will say, "Is that good?" And I'll say, "Yeah." And they'll say, "Is it clinically significant?" "I don't know." "Is it statistically significant?" "Yes." And you get into discussions about what that means. It's very hard to talk about that. And there are some ways you can make these things more clear, but traditional measures are very hard that way to translate. So there is a different kind of approach you can take to developing measures. And I'm going to talk about the child and adolescent needs and strengths as an example of that approach, because it really is sort of the leading exemplar of it. And the idea about it is that you actually design measures in a way to communicate the findings first and foremost. So instead of, for example, saying on a scale, how often is the child, I'll just use a traditional clinical thing, depressed, sometimes, always, very often. You say, is their depression something you need to do something about? Is it actionable? Instead of saying, does the kid do really well in school all the time or most of the time, you say, is that strength, doing well in school, something you can build your treatment around? Is it a centerpiece? So you change the way you do the anchors. And when you do that, you actually end up with measures that are very focused on the young person rather than services. You end up being able to take into account cultural and developmental contexts. You can talk more about the what of what's going on rather than the why, so you're agnostic, to use a phrase, with regard to etiology. How does that sound? Does that make any sense at all? Thank you. It did to the researcher, the rest of you, well, you're tough.